Welcome to Urothelial Cancer Preceptorship 2025. My name is Dr. Chow, Kuan, an anatomic pathologist from University Malaya. In the next 30 minutes, I will be presenting the pathology and biology of urothelial carcinomas. This presentation will begin with the basics of urothelial carcinoma. This is then followed by a deep dive into the WHO classification and histology of urothelial tumors, followed by its molecular pathogenesis and the differences between bladder and upper urinary tract urothelial carcinoma. And finally, a brief look into the latest cutting-edge research and technologies available for use. Urothelial carcinoma is a malignant epithelial neoplasm arising from the epithelial lining of the urinary tract that is called urothelium. Majority of tumors arise from the urinary bladder, followed by the upper urinary tract, which entails the ureter and renal pelvis, and only rarely does it arise from the urethra. The cancer occurs mainly in elderly males, and if found in young patients, you have to consider the rare genetic disorder of Costello syndrome, which is an inherited autosomal dominant mutation of the HRAS gene. Bladder cancer is the 9th most common cancer worldwide, occurring in 5 to 6 individuals out of 100,000 people each year. Higher rates are reported in Europe and Northern America, and in general, the bladder cancer is about 6 times as common in high-income countries as compared to low-income countries. In fact, 55% of all bladder cancers and 43% of bladder cancer deaths occur in countries with a very high Human Development Index. Fortunately, in Malaysia, the bladder cancer ranks only as 15th, affecting less than 3 individuals per 100,000 each year. Apart from gender, age, genetics, and geographical location, there are many modifiable risk factors for urothelial carcinoma. Is a major modifiable risk factors for urothelial carcinoma. 50% of cancer cases are thought to be attributed to cigarette smoking. Smokers have up to 6 times the risk of developing urothelial carcinoma in comparison to the general population. The risk increases with the duration and intensity of smoking. Smoking cessation reduces the risk and approaches baseline in about 20 years. The effects of cigarette smoking are linked to multiple chemical agents such as 2-naphthylamine. These indirect carcinogens are metabolized in the body, triggering carcinogenesis through the formation of DNA adducts, which are then filtered by the kidneys and concentrated in the urine. Polymorphisms in GST-M1 and CYP1A1 modifies one's ability to detoxify these carcinogens and hence become determinants of risk. Apart from cigarette smoke, there are multitudes of occupational carcinogens present in multiple industries. For instance, aromatic amines affect workers in rubber, dye, leather, textile, and paint industries. Diesel exhaust increases the risk in petrol station workers and truck drivers. Some environmental carcinogens, such as polycyclic aromatic hydrocarbons, are released from industrial emissions and become part of air pollution, thus putting entire populations at risk. Another risk factor is the microorganism Schistosoma hematobium. It is the ova and not the adult form of this parasite that causes urothelial cancer. The ova is deposited in the muscle bladder wall, inciting a severe chronic inflammatory response extending into the overlying epithelium. Over time, the inflamed urothelium barrier becomes dysplastic and subsequently cancerous. While it is true that 70% of tumors caused by Schistosoma hematobium are squamous cell carcinomas, the remaining 30% in the bladder are actually urothelial cancers. The same chronic inflammatory mechanism is also how indwelling catheters and neurogenic bladders increase the risk of urothelial cancers. In the former, the tip of the indwelling catheter continually irritates the bladder mucosa, while the latter, the urine itself, acts as an irritant to incite the inflammatory response. Certain medications, usually cytotoxic drugs such as clonazepam as well as cyclophosphamide, are used in the treatment of lymphomas and sarcomas. These drugs also increases the risk of urothelial carcinoma. Phenacetin, an over-the-counter analgesic used during the 19th and 20th centuries, have since been banned in many countries and has been documented to increase the risk of renal pelvis and ureter cancers. Aristolochic acid is a carcinogenic and nephrotoxic nitrophenolthrein uh, carboxylic cyclic acid produced by Aristolochia plants. An etiological link between upper urinary tract urothelial carcinoma and aristolochic acid exposure through the ingestion of Aristolochia-based herbal medicines or contaminated wheat grains has been established in several populations. These are mainly found in those people living in Taiwan, China, and Balkan regions. Such as external beam therapy and brachytherapy for the treatment of cancer, such as prostate cancer and uterine cervical cancers, also increases the subsequent risk of bladder cancers. Radiation treatment is also performed for patients treated with ankylosing spondylitis, and studies show that these incidents in these patients are also increased. Similar increased incidence of urothelial carcinomas are also found in the survivors of atomic bomb detonation in Japan. Clinically, patients with urothelial carcinomas present with mainly hematuria, which can be micro or macroscopic. If in the bladder, they may have irritative bladder symptoms such as dysuria, frequency, and urgency, which may be mistaken for urinary tract infections. In the upper tract, they could have hydronephrosis and flank pain instead. As with all malignancies, they also have constitutional symptoms such as weight loss, appetite loss, and fatigue. Only in advanced or late stages, they may have bone pain from bone mets or swelling and lower limb edema from nodal metastases. The basic investigations for a patient suspected with urothelial carcinoma is largely based on imaging to visualize the tumor non-invasively. Serology is often taken for biomarkers, cystoscopy for direct visualization of the tumor, as well as to obtain tissue biopsies for histopathology confirmation, and if the tumor cannot be biopsied, urine can be used to obtain the cell samples for urine cytology. Urothelial carcinoma is but a subset of urothelial tumors. Urothelial tumors can be divided into invasive and non-invasive. The invasive component is determined if the tumor has gone beyond the mucosa and invaded into the underlying soft tissue. The designation of flat or papillary is dependent on whether the tumor has finger-like projections or not. These finger-like projections has nothing to do with invasion. Tumors can be classified into 5 categories: papilloma, papillary urothelial neoplasm of low malignant potential or PUN lump, low-grade non-invasive papillary urothelial carcinoma, high-grade non-invasive papillary urothelial carcinoma, and urothelial carcinoma in situ. Each of these have their own recurrent rates and post-treatment progression rates towards carcinoma. On the other hand, with regards to invasive neoplasms, we only have the invasive urothelial carcinoma. Staging of urothelial carcinomas, especially for the bladder, is rather unique. Firstly, it has a TA stage, which is for all non-invasive papillary urothelial carcinomas, and a TIS stage, which is for urothelial carcinoma in situ. The remaining T1 to T4 stages is dependent on the depth of invasion, be it into the lamina propria, the muscularis layer, the perivesical tissue, or into adjacent organs. Take note that although T1 tumors are non-muscle invasive, they have invaded into the bladder lamina propria. Another distinction to note is the end stage, which assesses lymph node involvement only in the true pelvis and the common iliac nodes. If lymph nodes outside these nodes are involved, they are considered as the M or metastatic stages. Now we will take a deeper dive into selected topics beginning with urine cytology. Urine cytology is a non-invasive, relatively inexpensive test in detecting high-grade or aggressive lesions, especially when biopsies cannot be reliably performed, like in the flat lesions or in the upper urinary tract. It is also a great tool for screening and following up surveillance in monitoring recurrence. However, its utility is often diminished by poor sample collection techniques, resulting in poor utility. To maximize diagnostic accuracy, there are a few tips in sample collection. Firstly, samples collected can be spontaneously void or assisted through catheter and washings. It is important to document which method was used, as the cells in these assisted urine collections tend to be clustered and may give the wrong impression if they are neoplastic. If they are naturally voided, do not take the first voided urine sample in the morning. This is because urine is a poor preservative medium, and cells that have been sloshing around in the bladder overnight are likely to be degenerate. Instead, take a second voided urine sample. A practical approach would be to have the patients have their breakfast first before collecting the urine sample, because most patients will already have urinated the moment they wake up, and by the time they finish breakfast, it will be around 1 to 2 hours later, and therefore a second urine sample can be easily obtained. For the same reason, avoid collecting urine samples from the urine bag, as the cells would likely be degenerate. If absolutely necessary, collect the sample from the sampling pot on the catheter tubing and not from the drainage bag. Clean and clamp the tubing for about 10 to 15 minutes and allow the urine to accumulate. After that, collect the urine from the pot using a sterile syringe and transfer the urine to a clean, sterile container. All urine samples should be collected in a sterile container and closed tightly with a lid to prevent contamination. Urine samples collected should be sent to the laboratory without delay, or if there are any delays expected, store it in a fridge and not a freezer at 4 degrees Celsius. Urine cytology is reported based on the Paris system, which focuses on detecting high-grade lesions like high-grade non-invasive papillary urothelial carcinomas, carcinomas in situ, and invasive urothelial carcinomas. It examines individual cells exfoliated into the bladder and is flushed out together with the urine. It utilizes the nuclear features such as a high NC ratio of greater than 0.7, chromatin patterns, and nuclear membranes to decide if a high-grade lesion is present. Take note, urine cytology is mainly for the detection of high-grade lesions. A report of negative high-grade urothelial carcinomas does not mean that there is no tumor there. A low-grade papillary lesion may still be existing and requires further tests to confirm. As mentioned earlier, WHO classifies tumors into non-invasive and invasive neoplasms based on a wide set of morphological criteria determined under microscopy. Starting with the papilloma, this is the only non-invasive urothelial neoplasm that never progresses to urothelial carcinomas, nor does it recur post-excision, and therefore it is staged as PT0. The lesions present as a single solitary lesion in the bladder, but under the microscope, the tumor is composed of slender finger-like projections known as papillae. These papillary structures do not fuse. The papillae has a central fibrovascular core and is covered by urothelium of normal thickness and cytological features. The top layer of umbrella cells, identified by their vacuolated cytoplasm, remain present. This tumor is driven by RAS-ERK pathways but not by TERT promoter mutations like in the other non-invasive urothelial neoplasms. In the presence of more than a single solitary lesions, other diagnoses should be considered and sought. Contrast, the papillary urothelial neoplasm of low malignant potential or PUN lump have markedly thickened urothelium covering the papillae. The cell nuclei are also mildly enlarged and have a monomorphic appearance while maintaining its nuclear polarity. Unlike the papilloma, PUN lump tends to recur in 1/3 of cases. It also has a very low risk of turning malignant, as low as 4%, and is therefore staged as PTA instead of PT0. Its molecular pathogenesis is poorly understood, but have been found to have either TERT or FGFR3 mutations involved. Risk of recurrence appears to be higher in patients with multiple tumors, inverted growth patterns, and the presence of TERT promoter mutated gene. Non-invasive papillary urothelial carcinoma, on the other hand, usually have fused papillae with a thickened neoplastic urothelium. The nuclear polarity is lost, and the nuclei are enlarged and pleomorphic. Mitotic activity is seen above the basal layer, but only very occasionally. About 10% of cases progress to carcinoma, and half of the cases tend to recur after treatment. The main molecular drivers are FGFR3, HRAS, and the MAPK pathway. Additionally, TERT promoter mutations are also common in as many as 70 to 80% of low-grade tumors, and appear to be more so in tumors with the FGFR3 mutation. High-grade non-invasive papillary urothelial carcinoma is a urothelial neoplasm characterized by papillary structures lined by urothelial cells with marked architectural and cytological disorders. The basement membrane continues to remain intact and unbreached. The malignant cells are mitotically active, and the mitosis can be seen above the basal layer throughout the full thickness. While we expect the papillae to be broad and thick, this is not always so. Being high-grade, these tumor cells are less cohesive and therefore are easily sloughed off into the urine. They have a high rate of recurrence and the risk of prognosis to invasive carcinomas. Unlike the low-grade, the high-grade tumors are related with TERP, TP53, and CDKN2A mutations. Unlike all other non-invasive urothelial neoplasms which present as papillary or polypoid masses on the bladder wall, urothelial carcinoma in situ are often flat and erythematous, mimicking bladder wall cystitis. They are normally multifocal and diffuse. On microscopy, they are characterized by the presence of cells that usually have large pleomorphic nuclei with hyperchromasia. They also may have an irregular chromatin pattern and irregular nuclear contours. There are several morphological patterns including plasmacytoid, neuroendocrine, and CIS clinging patterns. They only serve, however, to recognize the CIS, and there is no evidence of clinical prognostic implication. The driver mutations for CIS is similar with that of the high-grade tumors, which is TRT, TP53, and CDKN2A mutations. The distinction for invasive urothelial carcinoma is the presence of malignant urothelial cells beyond the basement membrane, invading into the bladder or ureteral wall. Depending on the precursor, the tumor may form an exophytic mass, or it may even be flat and infiltrative into the bladder wall. The tumor cells are generally pleomorphic, enlarged, and hyperchromatic, with loss of nuclear polarity. Again, just like any high-grade and invasive tumors, the genes involved are TERT, TP53, and CDKN2A. Invasive urothelial carcinomas are known for its diverse morphological appearance. As alluded to earlier, it can be flat and infiltrative, exophytic and polypoidal, or papillary. The common diagnostic feature is the presence of stromal invasion, identified by either irregular angulated cords, nests, or detached single cells lying within the stroma. Additionally, there may be stromal reaction, and this reaction can range from the common stromal desmoplasia, myxoid change, or dense inflammatory infiltrates. Other times, there may be retraction artifacts where there is an artifactual space is formed between the tumor border and the surrounding stroma. Of course, presence of tumor cells within blood vessels and lymphatics is another telltale sign of invasion. As alluded to earlier, invasive urothelial carcinoma is remarkable for its diverse morphological appearances. A single lesion can display an admixture of conventional urothelial carcinomas and various well-defined histological subtypes. They can have divergent differentiation ranging from squamous to glandular to trophoblastic and clear cell Müllerian. They may also have different subtypes such as micropapillary, nested, microcystic, tubular, plasmacytoid, sarcomatoid, lipid-rich, and so on and so forth. Of these, squamous differentiation is the most common, accounting for up to 30% of cases. Alongside with sarcomatous and micropapillary subtypes, these tumors are the aggressive variants. Since many infiltrative or invasive urothelial tumors are mixed type, each variant is reported with an estimate of its volume in 5% increments. Urothelial carcinomas also harbor a high number of variable mutations, suggesting that these are largely not inherited but acquired from carcinogens. From the Cancer Genome Atlas, about two-thirds of mutation signatures are found in the ApoBac mutagenesis. Normally, the enzyme ApoBac cytidine deaminases the target viral DNA to prevent viruses from copying themselves and replicating. In cancer, this enzyme mistakenly edits the urothelial cell DNA, contributing to tumor development. Another important mutation pattern involves the ERCC2 gene, which encodes a protein that helps repair damaged DNA through a process called nucleotide excision repair. When ERCC2 is mutated, the cell's ability to fix DNA damage is impaired, allowing mutations to accumulate and cancer to grow. Another frequent mutation in bladder cancer in all stages is the TERT gene, which controls the enzyme telomerase. When TERT promoter gene is mutated, telomerase is turned on, allowing cancer cells to keep dividing without dying. Mutations in cell cycle genes such as p53 and RB1 causes unregulated cell division, while RTK-AKT pathways increase cell growth signaling. In addition, the direct impact of genetic mutations, there are also indirect effects caused by changes in epigenetic regulations. The epigenetic regulations governs how DNA is organized and accessed. Mutations in epigenetic regulatory genes such as ARIDIA alter the way DNA is packaged, leading to changes in gene expression and consequently affecting cell behavior. Urothelial carcinomas arises primarily from two distinct molecular pathways, which underpins the development of non-muscle invasive urothelial carcinoma and muscle invasive urothelial carcinoma. The first is the FGFR3 as well as the RAS pathway. This forms majority of superficial, low-grade, non-muscle invasive urothelial cancers and are characterized by activating mutations in the fibroblast growth factor 3, HRAS, and PIK3CA genes. These mutations drive the oncogenesis primarily through RAS-MAPK pathways and the PI3K-AKT signaling pathways. Of interest, FGFR3 and RAS mutations are typically mutually exclusive, suggesting they converge similarly downstream in the downstream signaling pathways. These alterations are associated with papillary low-grade tumors that tend to recur but rarely progress to high-grade or invasive disease. Tumors following this pathway is often indolent, with a high recurrence rate but low risk of progression. The second is the TP53 and RB gene pathway. High-grade muscle-invasive urothelial carcinomas frequently harbor inactivating mutations in the tumor suppressor gene for p53, as well as the retinoblastoma protein gene RB1. TP53 mutations lead to loss of cell cycle arrest and defective gene repair and resistance to apoptosis, while the RB1 pathway alterations, including loss of P16, further compromise cell cycle control at the GS checkpoint. The genetic changes are often accompanied by high levels of genomic instability, as well as additional mutations in the chromatin regulatory gene. Tumors arising from this pathway are typically high-grade, aggressive, and have a great propensity for invasion, metastasis, and poor prognosis. Expression profiling divides urothelial carcinomas into two main molecular subtypes, luminal and basal, with further subdivisions within the luminal subtype. These subtypes differ in their relative expression of markers of basal squamous differentiation, for example CK5, CK6, CK14, and CD44, and markers of urothelial differentiation such as CK20, uroplakins FGFR3, FOXA1, and GATA3. Basal tumors are usually more aggressive and tend to invade deeper into the bladder wall and are associated with shorter survival compared with luminal tumors. Basal tumors are generally more sensitive to cisplatin-based chemotherapy, and patients with these tumors tend to gain the most survival benefit. Luminal tumors, on the other hand, with high immune infiltration, respond better to immune checkpoint inhibitors such as PD-L1. However, basal tumors, especially those with high PD-L1 expression, may also be considered for immunotherapy. Knowing whether a tumor is luminal or basal can help decide who should get chemotherapy before surgery and who might benefit from immunotherapy as well. However, it has to be noted that there is often significant overlap and subtypes, resulting in further studies which is required to confirm its usefulness. Let us now compare the biology of urothelial carcinomas arising in bladder against those arising in the upper urinary tract. Bladder urothelial carcinomas arises from the endoderm-derived urogenital sinus, while the upper urinary tract urothelial carcinomas originates from the mesoderm-derived ureteric bud, and this comes off the mesonephric duct. These two distinct embryological origins contribute to the differences in their biology, genetic profiles, and clinical behavior. Bladder urothelial carcinomas is also significantly more common, with an incidence of approximately 10 per 100,000 against the upper tract urothelial carcinoma, which only occurs in 1 to 2 patients per 100,000 per year. Both conditions predominantly affect older adults around the age of 73 and has a stronger male predominance. However, this male predominance is markedly less when looking at UTUC in compared to BUC. Bladder cancer rates are also highest in the North America and Western Europe, while upper tract urothelial carcinomas peaks in Asian regions and Balkan states, suggesting a very different environment or genetic influence. Both cancers share common risk factors such as smoking and exposure to aromatic amines. However, their specific risk factors diverge significantly. Bladder cancer is strongly associated with chronic cystitis and prolonged indwelling catheters, as well as any conditions giving rise to chronic inflammation. In contrast, upper tract urinary carcinoma has a unique association with Lynch syndrome, aristolochic acid exposure, as well as phenacetin use. These sporadic risk factors help explain the geographic clustering as we discussed earlier. The molecular profiles also reveal fundamental differences in tumor biology. Bladder cancers more frequently harbor high-grade mutations such as TP53, ARIDIA1, RBG1, and ERBB2, and these are associated with more aggressive invasive cancers. Meanwhile, upper tract tumors show higher rates of FGFR3, HRAS, and CDKN2B mutations, which are linked to less aggressive tumor behavior. Both present with hematuria, but their clinical course differs markedly. Bladder cancers presents typically with irritative symptoms such as dysuria, urgency, and frequency, and are often mistaken for urinary tract infections. Upper tract patients, however, present with flank pain and hydronephrosis. Unfortunately, these symptoms often appear late in the disease course, and the delayed presentation contributes to a stark differences in staging, with only 15 to 25% of bladder cancers having muscle invasion at diagnosis, whereas a concerning 40 to 60% of upper tract cancers have already invaded the muscle at presentation. These differences have profound clinical implications and translate to a more aggressive treatment and treatment requirements, as well as a general worse outcome. We will now wrap up by examining the latest breakthroughs and transformative trends shaping the future of urothelial carcinoma pathology. While urine cytology remains a cornerstone in detecting urothelial carcinoma, conventional urine cytology has a sensitivity of just 67%, missing many early or low-grade tumors. Advancements in AI, staining, and liquid biopsies are transforming this field. For instance, Precision Urine Cytology AI solution, or PUCAS, is an AI model that analyzes host-like images. It boosts sensitivity to 89.6% in a prospective study. PUCAS is also able to detect low-grade tumors with 82% sensitivity, far surpassing the standard cytology's 56%. It also reduces unnecessary endoscopic tests by 57.5%, with a negative predictive value of 96%. Innovative stains like acridine orange fluorescence and cell detect enhance visibility. Acridine orange predicts high-grade tumors with 88% accuracy, while cell detect's red-green differentiation achieves 94% sensitivity for urothelial carcinomas. Liquid biopsy also bridges the gaps by detecting molecular markers in the urine. Third promoter mutations, found in about 60 to 85% of bladder cancers, provide a non-invasive diagnostic cue and early tumor detection. Combined with FGFR3 mutations, these biomarkers refine both the risk stratification and enable early intervention. Apart from cytology, histologic and digital innovations are also revolutionizing how we diagnose and manage urothelial carcinomas. First, recognizing histologic variants is critical. Aggressive subtypes, as mentioned, like squamous, sarcomatoid, micropapillary, and plasmacytoid, correlates with advanced stage, metastasis, and poor survival. Quantifying variance also matters. The non-conventional differentiation number, or NDN, which counts distinct histopathologic patterns, actually predicts lymph node involvement. For example, an NDN more than 2 doubles the risk of metastasis and therefore guides surgical planning. Integrating histology with molecular and genomic data unlocks personalized insights. Luminal tumors defined by FGFR3 mutations often respond well with targeted therapies, while basal subtype enriched with P53 alterations may require aggressive multimodal approach. The synergy between morphology and genomics is also reshaping prognostic models. The digital tool and AI algorithms are also transforming the workflows. For example, automated tumor grading reduces subjectivity, and AI models are now able to distinguish low from high-grade tumors with a 92% accuracy. Tumor volume and invasion depth, a once labor-intensive task, can now be quantified automatically. This precision aids in staging. For instance, AI-calculated muscle invasion depth predicts survival better than manual methods. Non-invasive biomarkers like bladder tumor antigen and nuclear matrix protein 22 are game changers. NMP22 is a protein found in the cell nucleus that is released into the urine when bladder cancer cells die. BTA, on the other hand, is a protein that is produced in higher amounts by bladder cancer cells and then released into the urine. Both biomarkers are used to help detect and monitor urothelial carcinoma. However, like PSA in the prostate cancers, it suffers from false positives due to other bladder issues like cystitis. Research is thus currently being performed to identify newer markers or combining other markers like TERT to obtain a higher specificity. Lately, biomarkers have also been discovered to drive treatment regimes. Nectin-4, which is overexpressed in 84% of urothelial carcinomas, is the target for enfortumab vedotin. This drug achieves 44% response rates in refractory metastatic disease. FGFR3 alterations, which are present in 20% of advanced cases, predict the response to erdafitinib, which studies show about 40% response rates even after chemotherapy failure. Then we have the DNA damage repair mutations like the ERCC2, which is critical for cisplatin eligibility. Tumors with DDR defects have 71% complete response rates to neoadjuvant cisplatin, in contrast versus 25% in DDR1 wild cases. The molecular stratification ensures that the right drug reaches the right person and prevents side effects in others. Finally, by integrating clinical imaging, histology, and genomic data, AI predictive models can forecast treatment responses for various drugs and treatment. AI clinical decision support systems can also integrate treatment guidelines and recommendations with patient data to suggest personalized treatment regimens. Thereby, this reduces trial and error in prescribing. Finally, AI surveillance systems can also flag high-risk individuals through biomarker trends and imaging, ensuring timely intervention. And this brings to an end my presentation covering the basics of urothelial carcinoma, followed by a deep dive into urine cytology, WHO classification of urothelial tumors, molecular pathogenesis of urothelial carcinomas, comparing bladder with UTUCs, and finally ending with the latest developments and future directions. I hope you have found the presentation helpful. Thank you for listening and see you in Putrajaya on 19th and 20th for the UCAP 2025. Signing off.